So let us start with the first question. The first question is a 49-year-old. Okay, so let me find a good color. A 49-year-old postmenopausal women of BMI 30 kg. Okay, try to note down क्या क्या लिखा है. It's very interesting. 30 kg postmenopausal भी है, overweight भी है. Comes to your OPD with joint pain and hot flushes. Okay, joint pain and hot flushes. What are the causes of her vasomotor symptom? So basically, what we are talking about is menopause. The chapter here is menopause. And in menopause, also, we are talking about the vasomotor and joint causes of menopause. Most likely, the joint problems are because of the start of osteoporotic components of the menopause, and the vasomotor symptoms will lead to hot flushes. So, the first question they are asking is what are the causes of her vasomotor symptoms? Right? This is for 4 marks. So, basically, you have to enlist all the causes of the vasomotor symptom. First thing. Second, what will you be your approach to counsel and manage the patient? आप counsel कैसे करोगे और manage कैसे करोगे? Now this question is this one is a slightly open-ended question for 4 marks. So you'll basically have to give a very essay, थोड़ा story types लिखना पड़ेगा. We'll come to that. And what are the absolute contraindications? Absolute contraindications of HRT, hormone replacement therapy. Okay, so let us go to the first question. What are the causes of her vasomotor symptoms? So, the first cause, basically, what is happening, we have to remember that in menopause, two things are happening. In menopause, the ovaries have stopped ovulation. Because ovaries have stopped ovulation, what is happening? Estrogen and progesterone are decreasing. Estrogen and progesterone. Estrogen and progesterone are decreasing, right? And the second thing that is happening is that the FSH and LH levels are increasing. Estrogen and progesterone are decreasing, FSH and LH levels are increasing. So because of this, there is a problem with the thermoregulatory nucleus of the hypothalamus. Because of this, there is a dysfunction of the thermoregulatory nucleus of hypothalamus. Okay, because of withdrawal of estrogen, there is increase in FSH and LH, rise in GnRH, FSH and LH. Because of that, the thermoregulatory nucleus of the hypothalamus is being affected. Because the thermoregulatory nucleus of hypothalamus is being affected, there is hot. This is the hot component. Patient will feel hot. ये समझ में आ गया? अब ईस्ट्रोजन और क्या कर रहा था? पेरिफेरल वेजोडाइलेटेशन हो रहा है बिकॉज ऑफ ईस्ट्रोजन डेफिशिएंसी. ठीक है, ईस्ट्रोजन कम होने की वजह से देयर इज पेरिफेरल वेजोडाइलेटेशन. Because of peripheral vasodilatation, there is flushed skin. So there is hot flushes, right? Hot is because your thermoregulatory nucleus of the hypothalamus is being affected, because of which what is happening that the patient is experiencing heat. And because of the decrease in estrogen, there is peripheral vasodilatation, because of which there is flushes. So ये एक point number 1, point number 2 and point number 4 are extremely important. उसके अलावा there are other chemical mediators also which are being affected. For example, there is decrease in norepinephrine, NORAD levels, decreased serotonin and increased beta endorphins. Decreased norepinephrine, decreased serotonin and increased beta endorphin. Now because of this, again what will happen? This will also lead to dysfunction of the thermoregulatory nucleus of hypothalamus. So because of the dysfunction of thermoregulatory nucleus and because of the peripheral vasodilatation, there is hot flushes. And also always remember, जहाँ भी possible हो ना, risk factors लिख देना. क्यों risk factors लिखने हैं अपने को? So that we complete the answer, right? Now this question is causes. And I think causes can be covered in this 1, 2, 3, 4. It's a 4-marker, so 4 causes can be written. DNB is not like your 11th, 12th exam, your MBBS exam. लिखते ही जाना है नहीं. To the point, enumerate करना है and you'll get the marks, right? But you still should mention some risk factors. So what are the risk factors? The risk factor is early menopause, सर्जिकल मेनोपॉज, आपने ओवरी निकाल दिया. स्मोकिंग, sedentary lifestyle, high BMI, ethnicity. Which ethnicity? So it is more in white than Asian women. हमारे women में it is less common, whereas white women, Caucasian women, it is more common. And environmental temperature. Hot tropical countries may it becomes slightly more common. Right? So early menopause, surgical menopause, smoking, all of these factors can always be elucidated when you're giving the answer for this question. Okay? So these are the causes. Now let's go to the next. What is the counseling and management? So the first and the most important thing you know that whenever you do counseling, you need to explain the disease. So explain the menopause, right? In counseling and management, दो components हैं. Counseling में explain that menopause is a natural physiological phenomenon due to estrogen deficiency. ये आप explain करोगे. फिर आप उसको बताओगे कि जो हॉट फ्लशेस है, नाइट स्वेट्स है, या मूड सिम्टम्स है, या स्लीप डिस्टर्बेंसेस है, जो भी है, these are common in menopausal transition. That means every person who is in perimenopausal state will have a problem, will have such problems. So this is extremely important. You have to reassure the patient. So what all are you doing? Remember this, these words are important. You explain. Whenever you're doing counseling, you explain, then you explain, reassure, assess, and discuss management. Explain, reassure, assess, and discuss management. So what are you explaining? You're explaining the disease. You're reassuring the patient कि ये सब में होता है, आपको चिंता करने की जरूरत नहीं है. Then assess. Assess for what? So you have to assess for symptoms and the risk factors. Risk factors like CHD, breast cancer, osteoporosis, venous thromboembolism, right? Because these become high risk as complications in perimenopausal state, especially when you're giving hormone replacement therapies. If you're giving HRTs, then in that case, these become very high, very important risk factors, right? So these have to be ruled out. Assess these कि ये है कि नहीं है, ठीक है, ये देखना पड़ता है. एंड लास्टली डिस्कस द ट्रीटमेंट ऑप्शन कि ट्रीटमेंट करेंगे कैसे. अब काउंसलिंग हो गया तो अब ट्रीटमेंट पे जाते हैं. अब ट्रीटमेंट आपको पता है कैसा होता है. एक होता है नॉन फार्माकोलॉजिकल, एक होता है फार्माकोलॉजिकल. उसमें भी नॉन एचआरटी मतलब एनीथिंग विच डज नॉट हैव एचआरटी, एंड द सेकंड इज एचआरटी. So basically we have three things: non-pharmacological, non-HRT, and HRT. Three things, right? So the first is non-pharmacological. Most important, we had seen क्या है patient को, BMI is high, she is obese. Second, she is perimenopausal and she is obese, postmenopausal obese. So most important thing is lifestyle modification. It is said that everything, all gynecological symptoms, even with a few kg, 2 to 3 kg weight loss, 10% of gynecological symptoms will resolve, right? So therefore, regular weight-bearing exercises. Now it is not just, there are two types of exercises, we know, there are two types of exercises. Either there is resistance training, that is strength training, resistance training, and other is aerobic exercises. So always whenever, wherever, whichever exercise you're talking about, always say that we will do resistance training as well as strength training. So resistance training as well as aerobic exercises. Resistance training as well as aerobic exercises, right? Then 30 minutes daily to improve bone mobility and reduce falls. All of this you can write. This is all very common. Avoid hot, spicy food and use cotton clothing wherever possible. ये सब. देन डाइटरी मॉडिफिकेशंस, उसमें क्या बोलोगे कि प्रोटीन कंटेंट इंप्रूव करना है, कैल्शियम सप्लीमेंटेशन देना है 1000 to 1200 मिलीग्राम पर डे, एंड विटामिन डी सप्लीमेंटेशन देना है कितना 600 to 800 इंटरनेशनल यूनिट्स पर डे. तो ये सब नॉन फार्माकोलॉजिकल एस्पेक्ट्स आपको बताने पड़ेंगे. एंड यू हैव टू रिड्यूस द सॉल्ट. सो कैल्शियम, विटामिन डी, exercise, clothing, protein intake, salt restriction, all of this is important. And lastly, sleep hygiene and stress reduction. Sleep hygiene and stress reduction. Then we come to pharmacological therapies. Pharmacological therapies में क्या क्या आएगा? SSRIs, SNRIs, right? So you have SSRIs, SNRIs, these are for hot flushes if HRT is contraindicated, right? HRT अगर नहीं दे सकते तो हम hot flushes के लिए क्या देंगे? SSRIs and SNRIs देंगे. कौन सा देंगे? पेरोक्सिटीन देंगे, वेनलाफ्लेक्सिन देंगे या एसिटालोप्राम देंगे. ओके, वेनलाफ्लेक्सिन देंगे, पेरोक्सिटीन देंगे एंड एसिटालोप्राम देंगे, राइट? VPE. Then we can also give gabapentin for severe hot flushes, and clonidine can also be given, but it is less effective, right? So VPEG, VPEG, that is venlafaxine, paroxetine, escitalopram, gabapentin. VPEG. These are the ones which are given. Okay. Hormone therapy. Hormone therapy is used to treat severe vasomotor symptoms. It is used to treat vaginal atrophy, osteoporosis, and prevention if eligible. Osteoporosis prevention if eligible. What is the regimen? अगर यूट्रस प्रेजेंट है तो E प्लस पी, क्योंकि हमको पी देना पड़ेगा, अनअपोज ईस्ट्रोजन नहीं दे सकते. बट अगर हिस्टेरेक्टोमी हो गई है तो ईस्ट्रोजन अलोन, ओनली ई, राइट? तो अगर हिस्टेरेक्टोमी हो गई है तो ओनली ई देंगे, अगर हिस्टेरेक्टोमी नहीं हुई है, यूट्रस है तो ई प्लस पी देंगे. एंड स्टार्ट कैसे करते हैं? ऑलवेज, दिस इज अ फंडामेंटल यू नीड टू नो, ऑलवेज स्टार्ट विद द लोएस्ट इफेक्टिव डोज. लोएस्ट इफेक्टिव डोज. सो पहले नीचे से स्टार्ट करो और फिर अप टाइट्रेट करना है, टाइट्रेट अप, राइट? सो यू हैव टू स्टार्ट विद conjugated ethinyl estradiol 0.3 to 0.625, right? Usually we give 0.625 से start करते हैं, right? So usually 0.625 से ही start करते हैं, but 0.3 से भी start कर सकते हैं. And estradiol 1 milligram per day, right? All of this can be given, and then you have to give it for not only least effective dose, also for the shortest duration. Least effective dose भी देना है, lowest dose for the shortest duration. Low, short, okay? Low, short, right? And then reassess after 6 to 12 months. तो key points क्या है? अगर non HRT है, right, for hot flushes, क्या दोगे? VPEG. VPEG क्या है? Venlafaxine, paroxetine, escitalopram, gabapentin. अगर आपका HRT है तो लो शॉर्ट रेजिमेन देना है. लोएस्ट डोज, जैसे फॉर एग्जांपल कॉन्जुगेटेड इथेनॉल एस्ट्रेडियोल मोस्ट कॉमनली यूज होता है, 0.625 milligram per day it is started at, and then for the shortest duration, so maybe 6 months. Then after 6 months you have to reassess, and then you have to take into account if you have to continue it or not, right? Okay, now what are the absolute contraindications? Absolute contraindications, okay, for HRT. So if there is undiagnosed or abnormal vaginal bleeding, if there is known or suspected or history of breast cancer. पता है ब्रेस्ट कैंसर है, शायद हो सकता है ब्रेस्ट कैंसर के पहले हिस्ट्री ऑफ ब्रेस्ट कैंसर है, यू शुड नॉट एवर ट्राई गिविंग हार्मोन रिप्लेसमेंट थेरेपी. Okay, then known or suspected or history or known or suspected estrogen dependent neoplasia. So for example, if there are certain liver tumors, hepatoma, estrogen responsive होता है, endometrial carcinoma, estrogen responsive होता है. In these cases, we do not give hormone replacement therapies. Then past history of DVT, current case of DVT, do not give because estrogen is thrombogenic. Then current or recent arterial thromboembolic disease. For example, if there is a stroke or myocardial infarction, in those cases we do not give because again thrombogenic. Then hepatic disease or liver dysfunction, because all of these are estrogen responsive, so we do not give. Known or suspected pregnancy, of course E plus P regimen हम कोई भी suspected pregnancy में नहीं देते. And allergy to estrogen, that is like a बस डाल दिया है डालने के लिए. But basically these 8 contraindications you should know and you should remember. इतना तो पता होना चाहिए कि these are the causes, these are the absolute contraindications to HRT. Clear? So this was for 2 marks. ये 2 marks के लिए था. 2 marks के लिए था, right? So this is how you complete an answer on HRT. Clear? Then we have the next question. What is the next question? Next question is question number 2. It states कि आपके पास एक 52-year-old woman है who has underwent hysterectomy, मतलब post hysterectomy है, post hysterectomy, and वो कैसा ये आपके पास present होके 5 years पहले हुआ था for UV prolapse and आपके पास आई है to the OPD with something coming out PV per vaginum. 5 साल पहले भी something coming out PV था, अभी भी something coming out PV है. एंड बावल ब्लैडर सिम्टम्स नहीं है. ऐसा नहीं है कि बावल पास नहीं हो रहा है, स्टूल्स पास नहीं हो रहा है, यूरिन पास नहीं हो रहा है, ऐसा कुछ नहीं है, राइट? मोस्ट लाइकली हिस्टेरेक्टोमी यूवी प्रोलैप्स के लिए तो वेजाइनल हिस्टेरेक्टोमी ही हुआ रहेगा. वी विल कंसिडर इट, इट्स नॉट बीन रिटन बट वीएच ही हुआ रहेगा. सो नाउ व्हाट दे आर आस्किंग इज कि पहले भी समथिंग कमिंग आउट पीवी हुआ था, अभी रिपीट इज समथिंग कमिंग आउट पीवी हो रहा है. व्हाट इज द कॉज? व्हाट इज द डिफरेंशियल डायग्नोसिस? फर्स्ट क्वेश्चन. सेकंड क्वेश्चन, preventive measures. Okay, and third question, this is extremely important. This is an extremely important viva question also. viva में तो मुझे इतने मेरा केस था यूवी प्रोलैप्स का, मुझे तो वाइवा में यही पूछा था. यूवी प्रोलैप्स में इतना सारा इट वेंट इनटू अपाइकल प्रोलैप्स ओनली. दिस इज अ केस ऑफ अपाइकल प्रोलैप्स, राइट? पोस्ट यूवी देयर इज वॉल्ट प्रोलैप्स. सो ये वॉल्ट प्रोलैप्स के केस में वाइवा में मुझे यही पूछा था दैट व्हाट आर द प्रिवेंटिव मेजर्स, व्हाट आर द प्रिवेंटिव मेजर्स, व्हाई आर दे फोकसिंग ऑन दीस प्रिवेंटिव मेजर्स? बिकॉज you should, as a obstetrician or gynecologist, you should do those measures so that the patient doesn't land up with this, right? So yes, so the preventive measures. And lastly, enumerate the surgical options for her. कैसे करेंगे सर्जिकली मैनेज? कोई एक को सर्जिकल ऑप्शन को डिस्क्राइब करने को बोला है इन डिटेल, राइट? सो व्हाट आर द डिफरेंशियल डायग्नोसिस? या तो वॉल्ट प्रोलैप्स हो रहा है, या तो उसको पीओडी में से एंट्रोसील हो रहा है, या तो उसको रेक्टोसील हो रहा है, या तो उसको सिस्टोसील यूरेथ्रोसील हो रहा है. One of these things is going to happen. We do not know what all repairs was done. We do not know UV prolapse previously हुआ था तो क्या क्या रिपेयर किया था. We don't know that. But we at least know that UV prolapse का वॉल्ट है. So तो वॉल्ट नीचे आ सकता है, या तो एंट्रोसील नीचे आ सकता है, या रेक्टो या सिस्टोसील, right? These are the differential diagnosis. Apart from that, there is no other differential diagnosis per se. What are the preventive measures? तो आपने देखा रहेगा, we always study the steps. उसमें if you're doing an abdominal hysterectomy, ये vaginal hysterectomy था, but if you're doing an abdominal hysterectomy, then in that case, usually what we do? We do uterosacral suspension. That means uterosacral, which is the long-held uterosacral is tied with the long-held of the vaginal vault, right? And those two are tied together so that the vaginal vault is taken up to the uterosacral, right? So high suspension होता है. और VH में हम क्या करते हैं? हम करते हैं सस्पेंशन, ये हम क्या करते हैं? मैककॉल स्कल्डोप्लास्टी करते हैं, right? And AH में suspension of Mackendorf's and uterosacral ligaments to the vaginal angle during AH. So VH में we always do McColl's scaldoplasty, and in AH we will always do this uterosacral suspension. These are important preventive measures. ये हमेशा करने ही होते हैं. समझ में आ गई बात? पहली चीज. दूसरी चीज और क्या कर सकते हैं? There is something called closure of pouch of Douglas by high peritonealization. So what we do is we close the peritoneum high up in the pouch of Douglas. What that does, it prevents the enterocele formation, because we know this for a fact that most of the cases of vault prolapse start with enterocele formation, and that enterocele leads to a prolapse of the vault, right? So to prevent that enterocele, we are doing high peritonealization. Then treatment of predisposing factors. ये तो है, ये तो लिखना ही पड़ता है, इसलिए मैं बोलता हूँ हमेशा रिस्क फैक्टर्स को ध्यान में रख के लिखने का आंसर. तो रिस्क फैक्टर्स अगर आप याद रखोगे तो प्रीडिस्पोजिंग फैक्टर्स भी आप बोल पाओगे. से कॉन्स्टिपेशन, क्रॉनिक कफ, रेज्ड इंट्राअब्डोमिनल प्रेशर, all of these you have to prevent. So these risk factors can be utilized at any point in the entire paper, right? Okay. Now what are the surgical options? So surgical options for wall prolapse treatment is either it's a vaginal route or it's an abdominal route. From vaginal route, either you want to reconstruct the vagina or you want to obliterate the vagina. So reconstruction of vagina would be either through sacrospinous colpopexy, sacrospinous fixation that is, and iliococcygeal fixation, or uterosacral ligament suspension, right? And अगर obliterate करोगे तो Leaford's colpoclysis कर सकते हैं. And abdominal route में क्या करोगे? Abdominal sacrocolpopexy या laparoscopic sacrocolpopexy, सो करना क्या है हमको अल्टीमेटली, वॉल्ट को सस्पेंड करना है, वॉल्ट को सस्पेंड करना है। वॉल्ट इज कॉल्पो, कॉल्पो इज वजाइना। किससे सस्पेंड करोगे? अब्डोमिनल रूट से मैश यूज करके सैक्रोकॉल्पोप्लेक्सी करोगे, पेक्सी, एंड vaginal रूट में you will do attach that colpo, that is vaginal vault, to the sacrospinous ligament, that is sacrospinous colpopexy, sacrospinous fixation. If instead of sacrospinous ligament you're using iliococcygeus component, then it is iliococcygeus fixation. Okay, but that is not commonly done. What is commonly done is sacrospinous fixation. So now the question that they have asked is, you elaborate, describe one procedure. So I will describe both the procedures. Basic ही करना है मुझे और कुछ नहीं. Abdominal sacrocolpopexy and vaginal में sacrospinous fixation. Both of these I have described here. Abdominal sacrocolpopexy. हम सबसे पहले whenever we describe a surgery, always write down indication, principle, steps and complication. Always इतना तो लिखना होता है. Indication, principle, steps, contraindication, complication, right? So indication, what is the indication? Vault prolapse हो रहा है, sexually active female में vault prolapse हो रहा है, इसलिए we are not doing obliteration, we are preserving the vagina. And it's also indicated when maximum vaginal length and axis restoration are desired. Why this is important is because in sacrospinous fixation, the vaginal axis is altered. It goes slightly rightwards. So it might lead to mild dyspareunia. But here it is not going to do that. It's going to maintain the vaginal angle, right? What is the principle? The principle is that the vaginal vault or the cervix is suspended to the anterior longitudinal ligament over the sacral promontory using a mesh, right? That is the principle. Procedure, usually spinal or general anesthesia. General anesthesia is preferred because it gives good exposure and all, is given to the patient in supine position, not lithotomy, supine. Pharyngeal incision or lower midline incision. Lower midline is again preferred because of the exposure is given. Then sigmoid colon is deviated towards the left. Fine. Then vertical incision is placed over the peritoneum of the sacrum. तो वो सैक्रम के ऊपर का पेरिटोनियम आप इंसाइज करते हो, उसको डिसेक्ट करते हो और सैक्रम में एंटीरियर लॉन्गिट्यूडिनल लिगामेंट को आइडेंटिफाई करते हो. एंटीरियर लॉन्गिट्यूडिनल लिगामेंट आइडेंटिफाई होने के बाद उसके वहां से आप एक मेश प्लेस करते हो. वो मेश के दो एंड्स होते हैं. इट्स अ वाई शेप्ड मेश. इट्स अ वाई शेप्ड मेश. वाई शेप्ड मेश होता है. दिस वाई शेप्ड मेश, ये वाला जो पार्ट है, दिस इज अटैच्ड टू एंटीरियर लॉन्गिट्यूडिनल लिगामेंट. एक पार्ट एंटीरियर वॉल ऑफ द वजाइना पे जाएगा, दूसरा पोस्टीरियर ऑफ द वजाइनल वॉल पे जाएगा. So there you will suture them. And how will you suture them? Using non-absorbable sutures, right? So your one arm is attached to the anterior vaginal wall, other to the posterior vaginal wall, and the stem of the Y is attached to the anterior longitudinal ligament, right? And with non-absorbable sutures. And then after doing that, after the suspension, the peritoneum is closed over the mesh. आप mesh के ऊपर से peritoneum को close कर दोगे, and abdomen is closed in layers. Done. इसका success rate is very high. It has success rate higher than sacrospinous fixation, 80 to 100%. Reaches up to 100%. Right? Advantages is आपका vaginal axis and depth normal रहता है. Low recurrence rate होता है. Sexually active female में हम use कर सकते हैं. And if required, if there is stress incontinence, then it can be combined with Birch colpo suspension, right? Birch के साथ आप उसको combine कर सकते हो, करना हो तो, because both are abdominal route. What are the complications? Complications are, अगर इंजरी होगी तो किसको होगी? ब्लैडर हो सकता है, रेक्टम आप सिग्मोइड को डिविएट कर, रेक्टम को इंजरी हो सकती है, सिग्मोइड को इंजरी हो सकती है, यूरेटर को इंजरी हो सकती है. Then when you are dissecting the peritoneum, the presacral venous plexus is get injured. And the problem with that presacral venous plexus is that those veins which are there in the presacral area, they are coming from the sacrum holes, right? The sacrum, the windows of the sacrum. And so therefore, when they get injured, they get retracted and they go inside the sacrum. And the bleeding is very difficult to control, right? So that is a very important complication, that there is presacral venous plexus and the middle cerebral sacral artery vessel is getting injured. Extremely important complication. Then mesh erosion. Whenever the mesh can undergo erosion, and that can injure the bowel, and that can lead to bowel erosion, right? And mesh infection can happen, hemorrhage can happen, constipation or sacral pain can happen, and recurrence or failure of the suspension, but that is rare. Recurrence is rare, both in sacrospinous fixation of the vagina and the sacrocolpopexy. In both these cases, the recurrence is rare. एंड स्मॉल बबल ऑब्स्ट्रक्शन कब हो सकता है? अगर आपने जो मैश है उसके ऊपर पेरिटोनियम को क्लोज नहीं किया, तो आपका बॉवल उस मैश के अंदर से हर्निएट होके ऑब्स्ट्रक्ट हो सकता है, राइट? इफ द पेरिटोनियम इज नॉट क्लोज्ड, right? And sacrospinous colpopexy, sacrospinous fixation. क्या है? तो wall prolapse is sexually active women where vaginal route is preferred, right? You don't want to open the abdomen, you want to do a short procedure, you want to finish it off fast. The patient might not be in a very good state to do a abdominal thing, so we can do for this. तो इसमें करना क्या है? Suspension of vaginal wall to sacrospinous ligament, usually on the right side. Why on the right side? Because left side पे क्या है? Left side पे क्या है? Sigmoid, right? So that is why you will prefer the right side. Procedure. Procedure में क्या है? Regional or general anesthesia with patient in lithotomy position. A vertical incision is made on the posterior vaginal wall near the apex. तो आपका जो apex है उसके नीचे posterior part में एक incision देंगे, and फिर वहां से pararectal space में हम जाएंगे. And through the dissection of pararectal space, we will reach up to the sacrospinous ligament. There, we identify the sacrospinous ligament and we fix the vaginal vault with the sacrospinous ligament using non-absorbable suture or using Mia hook or non-absorbable suture. We don't have Mia hook, we use non-absorbable suture only. And then after doing that, we close it and that's it. So it's a short procedure, right? The success rates are very high, 90 to 95%, very good success rates. That's why recurrence rate is very low. And the advantage is, as compared to your abdominal route or laparoscopic route, the operative time is shorter, and there is a good long-term support. But what is the complication? The complication is that there can be, because the rectum is there, rectal injury, hemorrhage to the injury. Your sacrospinous ligament has pin structures passing through it, pudendal nerve, right, and pudendal vessels. So those can get injured. So injury to the pudendal vessels, then injury to the pudendal nerve. It can lead to buttock pain or paresthesias. Buttock pain or paresthesias. Then vault hematoma or infection. Vault के ऊपर hematoma या infection हो सकता है. Then, as I said, fifth point, very important, that the vaginal axis changes. So patients sometimes might experience dyspareunia. Might experience, not always. And lastly, the recurrence rate is rare. Recurrence rate is rare. Right? Now we come to the third question. The third question is that a 31-year-old sexually active girl has come with the complaints of vaginal discharge and is concerned about being at risk for cervical cancer. On PS examination, there's a small ulcer which is noted at the ectocervix. So, what are the diagnostic tests and to diagnose the cause of the lesion? What are the treatment options? And for CIN1, and what preventive measures can you offer for a cervical malignancy? What are the preventive measures? राइट? तो ये तीन चीजें अपने को देखनी है कि डायग्नोसिस कैसे करोगे, अगर CIN1 है तो ट्रीट कैसे करोगे, एंड प्रिवेंटिव मेजर्स क्या है. सो व्हाट आर द डायग्नोस्टिक टेस्ट्स? फर्स्ट, क्लिनिकल इवैल्यूएशन. हिस्ट्री लोगे, vaginal discharge, postcoital bleeding, risk factors like multiple partners, early sexual debut, or HPV exposure. And post-pill examination जो आपने किया, मैं आप you will assess the site, size, surface, margins of the ulcer. Then look for the friability, bleeding on touch, and associated discharge. ये सब आपका clinical evaluation हुआ. Clinical evaluation होने के बाद you go for cytological screening. And cytological screening is done using pap smear. You take the pap smear, right? And then it can be classified along with the Bethesda system and into what? atypical squamous cell of undetermined significance. In that case, you have to repeat pap smear after 1 year. Yeah, you can do HPV DNA, which is called reflex testing. Reflex testing, or you can do reflex testing. In that, if the high risk HPV is positive, then you do colposcopy. If high risk HPV is negative, then you repeat cytology after 3 years. That all we know. We know this. We have studied this, right? Then as H, that is high risk H cell cannot be excluded. यहाँ पे कॉर्पो बायोप्सी करोगे. अगर L सेल है तो कॉर्पो बायोप्सी करोगे. अगर H सेल और स्क्वामस सेल कार्सिनोमा है तो इमीडिएट कॉर्पो बायोप्सी करोगे. अगर एटिपिकल ग्लैंडुलर साइटोलॉजी है या एडेनोकार्सिनोमा है तो इमीडिएट कॉर्पो बायोप्सी करोगे along with endocervical curettage, right? Because you want to assess about the endocervical curettage, you will do immediately because you want to assess the endocervix in these cases, right? AGC and all. Okay. And if the age is more than 35 years of age, atypical endometrial cells are present and risk factors for endometrial carcinoma are present, then you will also combine it with endometrial sampling. It is called endometrial biopsy with endocervical curettage. Endometrial biopsy with endocervical curettage. This is for endometrial carcinoma, and endocervical curettage is for your atypical glandular cells, right? So that you will do because you want to assure that these atypical glandular cells are primary to the cervical cancer and not coming down from the endometrial cancers. So you want to rule out endometrial cancer, right? Okay. Then ये हो गया साइटोलॉजिकल स्क्रीनिंग. देन यू हैव द विजुअल इंस्पेक्शन. किससे करोगे? वीआई, विलाई. तो यू राइट अबाउट वीआई, यू राइट अबाउट विलाई. यू विल एक्सप्लेन इन डिटेल इट्स प्रोसीजर एंड ऑल, राइट? एंड देन अगेन एचपीवी टेस्टिंग. नाउ डायग्नोसिस, यहाँ पे एक अल्सर की बात की थी. तो अल्सर है तो पैप एंड वीआई विलाई इज सफिशिएंट. एंड द मेन थिंग आफ्टर डूइंग बोथ ऑफ दीज थिंग्स इज कॉल्पोस्कोपी. वीआई करने के बाद कॉल्पोस्कोपी करो, विलाई करने के बाद कॉल्पोस्कोपी करो, और यू कैन डू एचपीवी डीएनए, और यू कैन डू पैप स्मीयर along with HPV DNA, right? So PAP along with HPV DNA, that is co-testing. This is called co-testing. What is co-testing? PAP plus HPV DNA. This is called co-testing. So HPV DNA is done as a part of co-testing. Okay, it detects the high risk HPV viruses, HP viruses, and colposcopy. So in that 6 to 40x, usually what we do, approximately 20 times magnification is taken, right? But 6 to 40 times magnification can be taken, and then you detect what the acetoid areas, the mosaic patterns, punctation, etc., etc. And then we do that after doing a VI villi. So you basically stain it with VI villi, and then you do the colpobiopsy to see the acetoid areas, punctations, etc. And then you find out कि अगर fine punctations है तो CIN1 होगा, coarse है तो CIN2-3 होगा, right? And अगर invasive carcinoma है तो atypical vessels देखने को मिलेंगे. And फिर उसका आप क्या करोगे डायग्नोसिस में? बायोप्सी लोगे. तो इसको हम बोलते हैं कॉल्पोबायोप्सी. Colpobiopsies do a colposcopy and under vision take a biopsy. Colpobiopsy. Apart from that, endocervical curettage भी कर सकते हैं. This especially is for AGC, atypical glandular cells, right? Okay. And other investigations, if you think that it's an infective condition, right? In that case, you should send other investigations also, like a wet mount or a gram staining of the secretions, right? For tricho, candida, gonorrhea, chlamydia. That is basically all the organisms under KIT 2. All the organisms under KIT 2. So that you will do. And VDRL HIV test, of course. That is always done because you want to do the STD screening. Clear? Now, what are the treatment options for CIN1? The first is conservative management. Very important because this is the first important thing. CIN2, 3 mein, you will never write about conservative management. But CIN1, it regresses spontaneously. So observation is acceptable. Okay, this is not acceptable for CIN 2 or 3. It is acceptable for 1. Observation is acceptable. But you have to repeat pap smear at 6 months. Okay, then you can do ablation to treat if you don't want to do conservative management, either ablation or excision. In ablation, cryo, thermo, laser. Cryo में freezes lesion using cryoprobe at -20 for 5 minutes. Okay, उसको क्या बोलते हैं हम? Freeze thaw freeze protocol, right? Then thermocoagulation. That is a thermoprobe at 120 degrees. Okay, and this has less discharge and it has a good safety profile. And laser coagulation is CO2 laser use करते हैं. It has higher precision. Clear? Cryo, thermo, laser. इतने ablative procedures लिख देना. And lastly, CIN1. It is less commonly used, but we can do excision of CIN1 also. Either leads, nets, or cold knife. Leads is loop excision, right? So loop excision of transformational zone. So with the loop, you excise, okay? Basically, it's kind of a cautery only. It's a cautery types only. So it is loop using excision under the local anesthesia. It provides tissue for histology, and it has a very high cure rate, 91 to 98%. कोल्ड नाइफ क्या होता है? आपका नॉर्मल नाइफ, उसको हम कोल्ड नाइफ बोलते हैं, राइट? सो कोल्ड नाइफ इज डन अंडर anesthesia for large suspicions and endocervical lesions. So if it's a large suspicious endocervical lesion, and in that case we do cold knife. And then needle is used, and with that thermoprobe you are basically cauterizing it. So that's called needle cautery, needle electrode, right? And that we can do with much more precision. So nets, cold knife, right? And how do you ask for the follow-up? 6 months के बाद pap smear. Repeat pap after 6 months. What are the preventive measures? Preventive measures, which was the third part of this topic. Any preventive measure for cervical malignancy. If the current test as benign. Then एक होता है primary prevention, जिसमें HPV वैक्सीन आपके बारे में आप लिखोगे. फिर आप लिखोगे about secondary prevention. फिर आप लिखोगे about tertiary prevention. And lastly, behavioral and lifestyle modifications. तो primary prevention क्या होता है? आपका you are preventing the disease. Risk factors are present, you're preventing the disease. Secondary prevention is you're preventing the so there are 4 types of preventions: primordial, primary, secondary, and tertiary. Primordial is you're preventing the risk factors. Secondary, you're preventing the disease. Tertiary, you're primary, you're preventing the disease. Secondary, you're preventing the disease to progress further, and tertiary, preventing the complications. So primary में what will you give? HPV vaccine. Secondary is regular screening of the CA cervix. कि अगर disease हो गया तो उसको आप early stage में पकड़ोगे. तो regular screening करोगे with pap smear 3 yearly or HPV DNA plus pap smear 5 yearly or HPV DNA 5 yearly. That entire protocol you'll have to write. And tertiary prevention is agar CIN pata chal gaya, then you do an early treatment to prevent further complications. Clear? And behavioral and lifestyle modifications के बारे में आप थोड़ा लिख सकते हो. That you have to avoid multiple sexual partners, then you use barrier contraceptives, smoking cessation, and maintain good genital hygiene.